You don't have to. Okay, morning guys. So, Rachel said, still on the biomechanics course. Done the first practical assessment, still got a hand in the final bit, so still on the journey with this. But yeah, so Rachel asked me to come along and give the perspective of someone who's more clinically based as an orthotist and just give my journey, the whole thing, so how I started off in my career and where things have progressed to at the moment. So, sorry for being such a heavy slide in terms of text. Anyone who's been to any clinical presentations, it's just pages of text. I'll try and, there's not that much more of this much writing. So essentially, no, if you take someone an orthotist, the usual response is, what do you do? You know, you're an orthopedist or an orthodontist, what's an orthotist? So to summarise, essentially, we're fitting external scaffolding on the body at any level to improve function, whether it be an insole under the foot, an ankle brace, a knee brace. So a knee brace, we'd see someone who's had ACL injuries, sports injuries. So it's any sort of externally applied device to try and improve function. The course is typically a 4-year course, or when I did it, and it's only taught at 2 places. One is Strathclyde and one is Salford. 3 years, it was 3 years just lecture-based and 1 year of placement. I think Salford have now just made it 3 years because there's such a shortage of orthotists about. They just want to get people working as quickly as possible, whereas Strathclyde are still keeping it very much that way. Didn't know what it was when I went to my first day there. All I knew was off to uni, go and do something, and applied to physiotherapy. And they said at the time courses were full, but there's this new course, and this was going back to '95. New course about, do you want to do this? And then after the first year you can switch. So yeah, what is it? I don't know, I'll just turn up. Being from an Asian family, there are only 2 professions, either medicine or engineering. So it wasn't quite doctor material, so I thought, oh, I'll do physics instead. Yeah, so the types of patients we treat is really broad. We could see, typically, polio. You've got polio patients with the long metal calipers. That's where the role of an orthotist traditionally started, doing that. Now we'd see people who've had stroke, so you're making plastic splints, bespoke, because after a stroke they're going to get contractures. You want to try and improve joint ranges, maintain joint ranges, try and improve the efficiency with which they walk. We can see sports injuries, so you've got your knee braces, MSK injuries, back supports, children with scoliosis, born with severe curvatures of the spine, so you're doing full body braces to try and correct and derotate the spine. So it's such a broad area. So not, like with every profession, not every orthotist you meet is going to have the same sort of career pathway. Some are going to specialise in diabetes. With diabetes, it'd be diabetic footwear. And the challenge with a diabetic foot is they don't have any feeling, because they lose most of their sensation. So if they're wearing a bad fitting pair of shoes, they end up getting start off with a blister, turns into an ulcer, amputation, so on and so forth. And then you go on to prosthetics, where they get full limb replacements. So diabetic footwear is quite a big thing. And I'll go into footwear afterwards, so that sort of ties nicely into that. With myself, I've gone more into orthotic with insoles. So although orthotics generally could mean anything from a neck brace to a hip brace, my specialism is more in insoles. So just my quick snapshot of my journey. Graduated in 2000, started working with a company called Steeper doing prosthetics. Because the course was prosthetics and orthotics. So that was the glamorous end, because you see all the Paralympians, Oscar Pistorius at the time, Heather Mills, you know, they were all the big names. So did 2 years of that, got bored, senseless. Because all of the glitzy, glamoury stuff was seen by the company directors. Suddenly they go to the Paralympics. We, as graduates and regular prosthetists, you would just see the geriatric patients who need to go from there to there, use the leg to transfer from the chair to the toilet, and that's what you're doing. So after 2 years, you could do it on autopilot. I can't do this for the next how many years. So then I slowly moved into orthotics. And the thing I like with that now is even after 22 years, someone can come in, you're left scratching your head. How do I do this? It's still a challenge. You still don't know what's going to come through the door next. And so I worked for a couple of big companies. I worked at Cox Orthopaedics, a small family company in Whitechapel, and they got acquired by Mobilis. So it was at a Mobilis company training day, which I normally roll my eyes at, thinking, oh, just in time. Where there was the whole biomechanics, intrinsic biomechanics course was done in the space of about 5 hours. It was a very condensed version by Martin. And it was, I'd been doing my job about 8 or 9 years at that point, and it was one of those moments where your brain sort of explodes. Why is that? How did he do that? Why has he moved the leg and it's changed the leg length? Or why has he moved the shoulders and it's done that? So, the first part of your career, as an orthotist, you're just going through the motions. Flat feet, insoles, put something in, get the body straight, without any understanding, keep it simple, keep it working. Met Martin, did this, and it was just blown away. Came back thinking, what am I actually doing with these functional leg length difference? Because we'd stand someone up, yeah, you got one leg shorter, put a raise in, you're level, off you go, not realising you're actually making the problem worse. So I spoke to my boss about it at the time and said, oh, can I do the course? And he went, no, it's not relevant to what we do. So why did you do the course then? No, it's just an open day, so we did something, but it's not relevant to your job as an orthotist in the commercial setting of an NHS-based clinic. So it was almost one of those, just put it on the back burner for a little while. And so working at Halo Medical, after about 15 years, the company was struggling a little bit in terms of quality of products. So they said, oh, we'll assign different orthotists to improve different areas. So I got put in the orthotics, in the insoles department, to try and improve the quality and improve the manufacturing process and the final product. So before you can actually go and start talking to your seniors, or even the junior first-class students, you need to know what you're talking about. So it was a case of thinking, before I prove anything, or even talking to the technicians, I need to know my stuff. So it was a case of go back to the books. And you go back to the books, and it was only then you realise, why aren't I checking that? I've stopped doing that. I don't do this anymore. So it was an interesting learning curve to think, well, you've really got to start again. And only then, when you know you're actually 100% confident in what you're talking about, you can then start engaging with your peers. So, yeah, it was just a case of back to the books for the first few months, actually knowing what you're talking about. So with insoles, first thing that popped out was the whole way it was being explained had changed. The traditional theory with insoles was called the root theory. The feet have to be straight for the body to function correctly. So at the end of any insole, get the heel straight, there has to be an arch, then the foot will work. But there's a chap, an Australian guy called Craig Payne, he's got all sorts of blogs and things like that. There's a really good one called Running Research Junkie. He's got some really good blogs that he reviews papers and all that sort of thing. So it's definitely worth one to follow if you're into that, running biomechanics. So, primary tenet of Newton is force drives motion. First law, an object remains at rest or moves at a constant acceleration until an external force acts on it. So, in the relevance of this presentation, I'm going to be talking about the foot, pronation and supination. So the foot's going to either remain pronated or it's going to remain neutral unless an external force acts on it, that either being a muscle or the ground, the angle of the ground reaction forces all playing in there. When we start applying Newton's laws to joints, is then actually get to understand why we're using orthotics. Going off to Newton's laws, from there, the primary thing we're looking at is moments, because we're looking at moving a force. We're trying to initiate a rotation around the subtalar joint axis. Okay, so yeah, main thing moment, it's the measure of a tendency to cause a rotation about the pointer axis. It may not cause a rotation, but it's changing something, which I'm going to come to later. So typically, when we're looking at moments, example here is to measure the moment, you want your force and distance are related proportionally. So if I push further along with force X, it'll be easier to turn. If I push at a shorter distance using the same force, it'll be a different result there, a different measure of that moment. Simple analogy that I had to use. So one thing with me was I hate studying, absolutely hate it. And you've got to analogize the simplest way of understanding it. And I think it was sort of got by Einstein, saying if you understand your subject, you should be able to explain it to a child. So I always like to understand things like I'm explaining it to one of my kids. If they get it, I know what I'm talking about. Simple analogy, pen, put a pen on the table, put a book on it, see it falls to one side. Imagining that to be the subtalar joint. So the pen is the subtalar joint axis, the book is the body, or the foot essentially. So where you put that pen along the length of the book dictates which way the book's going to fall. Okay? Then if we assume the table's not there and I want to push the book up, the force needed at any given point along the length away from the pen will be different. So if I push the book at its furthest point, I need less force. If I move it further, press further in, I need higher force. So it's all building up to what we're going to do with an orthotic here. Another analogy is a seesaw. You've got someone sat on just one end of a seesaw, it's dropped right down. If I push from closer to the rotation point of rotation, I need a higher force. Further on, it's going to be totally different. So when we're looking at joint moments, we can further split them. Okay, so we're going from forces to moments. Now we're splitting moments further into internal moments and external moments. So with the subtalar joint of the foot, it's going to be in, or any joint, well, let's keep it a subtalar joint, it's going to be in equilibrium, it's going to be balanced when the pronation, external and internal moments are balanced, keep pointing to use that, with external and internal supination moments. So what I mean by that is with external moments, Newton's third law, every action is equal and opposite reaction. So for example, if you're walking along, you suddenly step on something and it tilts your ankle over. That's that external force causing that moment. Internally, we're talking about muscle strength. So if you've got a muscle that isn't overly active, it's going to tip the balance here. And with the subtalar joint axis, it literally is as simple as that. If either one of these is weak, and this isn't balanced, we're going to get a dysfunction. We're going to get an overload of forces here. And essentially that's what we're looking at. We're looking at forces. So, if you look at the foot on this side, can you see that clearly with the light?
Yeah.
Okay, so again, looking at the moments, we've got force and distance. Point of rotation is just under the ankle, the pivot point. The contact is underneath the whole foot. So if we were to try and say measure how much force is going along that Achilles tendon, let's call it X. Yeah, there's X amount of force going through that tendon. If we then move the heel off of the back, the position of the foot is still at 90 degrees. But has the force going down that Achilles tendon changed? Mm-hmm. So there's more force being used, so an internal force is being used to generate that moment. The foot, however, is still in the same position, but the forces in it have changed. With that force being applied further along from that pivot, the moment has increased. That heel, if there were no resistance from here, would drop down to get dorsiflexion of the joint. So you have to generate that force to keep it upright. So thinking of that whole stress going on that Achilles tendon, I can't remember the chap's name who did this, but 3 methods of dysfunction for any muscle. So I would like to explain it when I'm talking about my clients as a rubber band scenario. If you've got a brand new rubber band, do something ridiculous with it, it's going to be a problem, it's going to snap. If you've got an old crusty rubber band, do something normal with it, it'll snap. Or the worst of all 3, you've got an old crusty rubber band, do something abnormal, it'll fall to bits everywhere. So essentially that's how it is, I think, when it comes to training and performance as well, is you have to look at the whole thing globally. So we're looking at that slide where there's the internal and external moments. If you've got someone's foot is in a really severely pronated position, it could mean that the tibialis posterior, the muscle there, is like that crusty elastic band and is causing that imbalance in pronation and supination. So the two things, all sides of it have to be balanced. It could be an athlete who's had a a rest, or they haven't, following an injury, they haven't done anything for, let's say, 3 months, 6 months, whatever it is. They suddenly get back to high intensity training. Analogy-wise, the muscle's like the old elastic band. It's not used to that level of force at the moment. One I did, the daft one, is the book that was written, Born to Run. I don't know if you guys have read it, but that was at the start of the whole hype of barefoot running. So like most other people, I went, oh, this is going to improve everything, I'll go and run barefoot. Took the trainers off, got on the treadmill. I think it lasted about just over 5 minutes. And just hobbled off, went inside, couldn't do the rest of my workout, hobbled off. Ended up with a really bad trigger point along flexor hallucis. Analogy-wise, you could argue that was it a case that my muscles were like across the elastic band, having a normal load applied, or were they like the normal rubber band, having an abnormal load applied? So that the whole thing changes with each individual and their own biomechanics and joints. So it really does vary. So what's normal for one person is never normal for others. So I tend now not to use the one system approach, because you can't. We're all so unique that one approach doesn't work. So the whole basis initially of insoles being made on the root theory, where you want to get the foot straight, is flawed. Because not everyone's the same. So you have to use a system where you're balancing the forces, where there's that rotational equilibrium, you're going to get a better result. So that slide where we had the foot on looking at the side at the ankle. Let's look at it from the other angle now. We'll look at the foot from behind. Okay? So both feet, like that other slide, are in the same position, but we're looking from this end now. The one on the left is without an insole. The one on the right has the insole, but the feet are in exactly the same position. Yeah? So looking at the other way, sometimes we'll get people in for insoles who've got really pronated feet. You put the insoles in, they look down and say, they look exactly the same, they're not doing anything. Correct if you use the old approach, which is wrong, but the new approach is the fact that they are there and that nothing has changed to look at, so kinematically nothing has changed, doesn't mean they're not working. They've changed the loads going through those muscles. So for example, in this one, if we were to just isolate the tibialis posterior, we were talking about, with that one it could be you've got a high load going through tibialis posterior, but with the insole there, with that wedge, there's less force going through that tibialis posterior. So although nothing has changed to look at, we reduce the loads. So when it comes to insoles, if you'd say something, what's an insole, what's an orthotic? My first way of thinking would have been something you put under the foot to straighten it up. Which at the moment, you've got flat feet, you need an insole. But a more scientific approach to looking at insoles is more force guidance systems. So as you walk over it, it's changing the forces, the tensile loads, the compression loads, the way they're going through your feet when you're walking. But insoles get a lot of bad press. Okay, you do a Google review, you hear lots of people slating them, they haven't worked, they caused more problems, or they were really good and I met someone who said to do this, and now I've suddenly realised my feet are really bad because I've been wearing them, and now you get all sorts on it. But the problem with that approach is they're anecdotal, and none of them have any literature references to say they're not working for this reason, or this is the problem with them. And the other thing is, the key thing at the bottom is not any intervention is 100% guaranteed. You go for surgery, you sign a form saying, I understand this might not work and I could die. So it's the same with physiotherapy. You can have targeted physiotherapy, it might not get a result, but chances are it will. As long as we're following an evidence-based approach, so a method that's been used thousands of times in the same way and has given the best possible outcomes, is what we're going to use to get that best result. But there is a chance it might not work, like with everything else. A proper review would be done on there's a group called the Cochrane Collaboration, who are a group of researchers, and they will research every medical intervention. You find all sorts of papers, theses and everything, to say scientifically and academically, does this intervention work? Backed up with all sorts of, other information they can. And the evidence unequivocally says insoles do work. Okay, so they do reduce the forces gained through your feet. An analogy I like to give my patients is that insoles are like reading glasses. While you wear them, they work, they make life easier. As soon as you take them off, you still can't see anything. They haven't improved anything by wearing them, but they've made doing what you want to do more comfortable. As opposed to being like braces you put on your teeth, wear them for 2 years, and that's what most people think when they come in. Particularly with children, parents will bring children and say, insoles for flat feet. So after 2 years, you don't need to wear them because the feet will be nice and straight. But that's never the case. Take them off. After 10 years wearing them, and the feet will still do that because you've not looked at the causes of the internal moments that we went through earlier. So, back to the journey. Okay, so did all of that, got the insoles department all working quite nicely, products work, insoles were working well, there was less remake rates. COVID kicks in. So I go on furlough, put on furlough for 3 months. But being at home, I can just sit there doing nothing. But what can you do now? There's got to be an opportunity in all this somewhere. And so I developed an app. Got in touch with a few people, and what we designed was you put your foot on a bit of A4 paper, put it up against the wall, take 3 photos with your camera on your phone, and it gave the foot measurements exactly, width, length, and it could extrapolate circumferences as well. Did that, got some videos going that people could upload, record themselves, and then I could look at that remotely and formulate a prescription for a modular insole, not a custom-made insole. It turned into something much bigger than I was expecting it to be, and it was then starting to cost about £2,000 a month to run the servers, and I thought, I can't afford that. So it was shelved. Categorically, you could say yes, failure, didn't work. So what happened with that is, my employer and I parted ways, because it was deemed gross misconduct, that I was making something like this. And so we parted ways, and I set up my own private clinic. Started locoming to keep it all rolling during the day. The difference now was your reputation's on the line. So it's not like an NHS clinic where someone's come in and instantly, in an NHS clinic you've got 15 minutes, or 20 minutes now post-COVID to assess the patient fully. Check everything out, get it all right, do your assessments, prescribe an insole, write the prescription, put on your clinical notes, get the next one in. So it's a conveyor belt. So a lot of people would, you'd say, well, I wouldn't see that orthotist, I wouldn't see that physio. The difference is, you see that person in an NHS setting, they're limited to what they can do. Even with physios, their remit is to get you fit enough to get back to work. They're not going to want to fix the problem down to its root cause. Same with us, you've been referred in. The difference is, you're seeing someone for let's say, tibialis posterior dysfunction or plantar fasciitis. Your treatment is, treat the diagnosis. You've got a flat foot, take an impression of the foot, I'll get you a size 7 shoe, out you go, next one. When you're seeing privately, you've got to actually get to the root cause and fix it. So one lady came to see me after lockdown, and she had taken her son to see a private podiatrist. And when she came into my room and she went, "You haven't got any fancy equipment in here." My room is essentially about this size, there's a couch and a table. She went, "Oh, there's no fancy equipment." I said, "Oh, what do you mean?" So she'd gone to see a podiatrist who had, it was like the Batcave. There was all sorts of force systems, this, that, the other. And she went, "Oh, he basically got my son to stand on all of these things, generated readings, and then he gave us 2 pairs of insoles, a firm pair and a hard pair. Not custom made, off the shelf. These insoles cost 30 quid each." So what did we charge you for that? She went, £600. I'm in the wrong game here. £600 for 2 £30 insoles and just to stand on machines. So I said, what did he say was the cause of the problem? He didn't. So we need to come back every 9 months. Yeah, I bet he did. So her son is in his early teens, right? He's about this tall. The pain's in his heels. I said, he's just got tight muscles. That's what's causing his foot pronation. So the foot's being pulled out of position, the joint's being pulled out of position because he's got tight muscles. Did you give any stretches to do? No. So I said, right, so you haven't addressed the root cause. I said, you only need off-the-shelf orthotics, I agree. I said, you only need to pay £30 for them, maybe a handling fee on top, but you need to really stretch those muscles. Chances are, if your calves are tight, your glutes are probably weak. Gave her a course of exercises to do. Gave them some new off-the-shelf insoles, no point making custom ones. Came back one more time for a review, and that was it. Not see him after that. And I said, you've got to manage it yourself. You can't expect a therapist to be holding your hand all the way along. So the interesting thing then was, so I thought, I know everything about, I know to a high level what I need to know about foot biomechanics. An interesting one for me was this lady came in who was a rambler. Loves going up to the Lake District, does a lot of walking. And a lot of pain in the forefoot on one side. So got her in, made some insoles, took them away, supplied them, and then she phoned up and said, I'm having a problem with them. I said, okay, come in. So she said, the insoles are great. There's no pain in her feet when she walks. She said, the pain I'm getting in my ribs is crazy. She said, I don't want to take them off because I'm in more pain when I take them off. So in an NHS setting, you'd say, go and see a physio, not my problem. In a private setting, my reputation's on the line here. So I thought, she's come to me for help. I need to fix this. I need to know at least what's the cause of this pain that's moved somewhere else. Didn't know where to go or what to look at. Then I remembered Ryan Haynes. So, yeah, so I missed that slide. That's just about the whole hands-on versus technological side of assessments. Online search. So I phoned up Rachel, we had a chat in the car, and I mentioned Martin, and she said, yeah, it's going back some time. So I thought, right, invest in a bit more education, let's find out what's going on. So I actually called her back, and I did a freebie. I know you said not to, but I did a freebie just to check. And yeah, dysfunctional pelvis, tight QL, shoulders, the whole thing. So I did 2 treatments with her, and now she wears the insoles, and there's no pain. So it worked. It was a great learning curve for me, in that sense, to say I was only looking from the ground to the hips, but going further up, and different aspects of looking at the hips worked as well. So yeah, this intrinsic biomechanics is mind-blowing. So when we were here last time, looking around, huge variety of shoes, but most people here were in this sort of thing. So I thought we'll do a bit of talk on that. And why are people wearing them? What's the expectations here? So yeah, I mentioned the whole thing about running barefoot, didn't work, muscles got to be conditioned. From a psychology point of view, we found that people who wear, there were some trials done, people who wear the big cushion shoes tend to do them because they're comfortable. But people who go for the minimalist barefoot shoes are almost buying them with an expectation that they're going to fix something or improve something. So there's that whole psychological side of things that, you say, I'm buying that because it's going to fix my flat feet, or I'm buying it because it's going to improve the way my spine's aligned. Whereas if you buy something like this, it's either because someone's told you it's more comfortable, or it's just because you've bought them. These are really comfortable with them, they're great. So there's a whole psychology side of it as well, which it's not my area, I'm not going to go into it. But when it's come to, with the whole industry of making and, I wouldn't use the word referring, but the whole marketing ploy has been based on a few statements or a few hypotheses. First one is that pronation is predictive of injury. So every clinical trial done has shown that's not true at all. You can have totally pronated feet and be a top level athlete. Google Usain Bolt's feet, flattest feet you've seen, fastest man on the planet. The difference is his internal and external supination moments and pronation moments are balanced. So biomechanically, he's as good as it's ever going to get, even though he's got pronated feet. So all the whole marketing things, that anti-pronation shoes, pronation wedges, anti-pronatory wedges, all that side of thing, it's been shown to be a fallacy. It's not true. So that one's blown out the window. The next hypothesis that all individuals should be aligned identically. Okay. If you look at the face, it's not identical. There's asymmetries all over the body. Now, going back to that book analogy, remember that pen? You put the pen, put a book on it. Now, if I put a book on the pen in a certain place, the amount of force I need to lift that book is X. If I replace that book with another book, which is a lot bigger, in exactly the same position, by nature of the build of that book, the force needed to push at exactly the same length along it will be different. Even though alignment-wise it's exactly the same. So even though people may be aligned identically, it's not measuring the forces. So you can have two people with feet in a really rolled in position, tibialis posterior, let's say. One person's feet work really well, and you get twins with exactly the same feet, and the other one's doesn't. The other one gets lots of pains. In treating one of them, you find the axis, the subtalar joint axis, even though the feet look the same, is in a different position on both sets of on each twin. So even though they look the same, the amount of force is needed to push in that green area to lift the foot up is going to be vastly different to the other twin, where that green area may take up more of the foot. Tips over more easily. So that's just the pushing side of it. If you think of a door, big heavy door, put the handle at the furthest point away, it's easier to pull. Put the handle further in, the door becomes much heavier. You can't pull it, or you need more force to pull it. So that's the way the muscles are functioning. So tibialis posterior, on a foot with that subtalar joint axis, is further along this inner edge. It's like having the handle close to the hinge of a door. The tibialis posterior muscle really has to put a lot of work in to get that moving. Whereas when that axis is further along, a little bit of movement. So the handle's away from the hinge of the door, a little bit of force, tips that foot over. So that supination resistance test that we do, that shows that quite nicely. So the US military is where all this research started with regards to footwear types for runners, for running shoes. And a lot of it was based on the wet foot test. So typically, get out of the shower, look at the footprint you've made. Does it have a high arch, low arch, middle arch? So form and function, we've found, are not related. So this doesn't hold water either. So when I explain to all patients, form and function, you could have picture perfect feet and not be able to walk from here to here, or you can have totally pronated feet and be the fastest man on the planet. So it just doesn't work that way. Shoe technology is another thing which is really big at the moment. If you look at the old Nike running shoes from about 30 years ago, they were flat, essentially like minimalist footwear, almost. But now they've got the wedges, anti-pronation bits added on, materials technology, making them a bit more springy. The two things they're looking at is one is cushioning, for dampening forces when you're landing on that foot as a runner. The second is the geometry or the stiffness of the material in there to reduce pronation. An interesting study done, they found that with people who were excessively pronated, putting them in anti-pronation shoes reduced the pronation, but it increased the peak vertical forces going through the tibia, and they were suffering more injuries. But putting them in a shoe which was neutral didn't cause more injuries. So it's an issue with footwear. I always like to explain to my patients when it comes to insoles, is that the insoles are only as good as the shoes. So I always like to say, think of the insoles as the prescription and the shoe as the dosage. So you can have a low prescription in a high dosage or a low prescription in a low dosage. It really depends on the shoe you're going to wear. So people will come in saying, oh, I've tried these and they're rubbish, but they've come in wearing really thin court shoes. They're not going to work, so go and try them in trainers. No, I've done that. Go and try them in trainers. And they'll come back, yeah, they're fine in trainers, but I don't want to wear them in trainers, I want to wear them in these. So the shoe's a key thing. So there's two sides of the fence here. You've got your barefooters, who are constantly slagging off the sturdy shoes. You've got the sturdy shoes lot who are ridiculing the barefooters. I sit on the fence because I don't think it's about the shoes. It's about your biomechanics. There's no evidence suggesting orthotics, or sturdy shoes, weaken feet. There's no evidence at all anywhere. In any of that Cochrane collaboration papers that are done, there's no evidence to suggest it. The analogy people will say is they're like a crutch, or they'll say, the first thing you hear people say, it's like having your arm in a plaster cast. You take your arm off after, you take the cast off after 4 weeks, the arm's shriveled away, it's all weak. Yeah, but the arm's not moving within the cast. On an insole, remembering their force guidance systems, the foot is still dynamic, it's still moving on the insole. All we're doing is playing with the forces. So your foot's still moving, so it can't get weaker. If you were to look at the most aggressive shoe possible, a ski boot, based on this logic of the barefoot school of thought, every skier in the world will have the most pronated feet, because the feet aren't moving. And again, doing the couch to 5K, if you've got someone who's never run, and suddenly they want to start training, and they're wearing supportive shoes, Hoka ones, really firm, you can't say the feet are going to get weaker because they've started wearing them. They're going to strengthen up in some way. So where does that leave us for shoe selection when it comes to running? What would you now think? Well, based on what you just said, what do you get? So a study done by these guys has found that comfort is really what it's based on. So if you're going to get a pair of training shoes, you get shoes, you try them on, with your eyes closed, well, they're comfortable, that's the shoe you should wear. But I would say that and a whole dose of Pilates maybe as well. Okay, or sensible conditioning techniques, sensible training techniques. Shoes are just one part of the equation. You can't look at them. So, like the analogy I gave earlier, when I was running on that treadmill barefoot, was it a new rubber band or was it an old crusty rubber band? Someone else who may have done exactly the same thing but is more used to wearing minimalist shoes may have done really well in it. So it's each individual's biomechanics that allows shoe selection. I don't think you can just say that one thought process fits everything. If for example, like Reggie wearing those Vibram 5 fingers, they work for you, but I wouldn't wear them. But it depends. Your biomechanics are totally different.
I wouldn't wear them all the time.
Yeah.
So I wouldn't wear them running. So.
Yeah. Which leads on to the next slide. So that's running shoes. What about day shoes? What are you going to wear during the day? So when I get people in, I'll tell them walking is about two things. So you've got the engines of the feet, the control room of the feet, up here, and you've got the gear levers, or the lever, down there. Everything in the middle, it's a simplistic view, is more consequential. Okay? So walking, as soon as the heel hits the ground, you're starting with a whole series of internal rotation. So your glutes have to fire to slow that down. As soon as you get to mid-stance, the glutes got to stabilise the other hip. So you're not dipping or doing anything like this. Then as soon as you're going into propulsion phase, the glutes are firing, starting that external rotation in again. So the engine room of feet is higher up here. So it was one of my teenage patients, but he goes, I got flat feet because of a weak arse. So, exactly. It's exactly what it is. And chances are then you work down the chain. If the glutes are weak, the hamstrings are probably tight, or the calves are tight to compensate for stability mechanisms. So it's all up here. The key feature down here is the gear system needs to work properly, which is the big toe. So as far as day shoes are concerned, wear what's comfortable, but my only thing is that the toes should be spread out. If you're wearing shoes that are pinching in, the old winkle pickers or cowboy boots or whatever, as soon as you're doing that, you're inhibiting the gear system of the foot. Your foot's going to take the path of least resistance to propel you forward, and there's going to be an overloading of forces. That overloading of forces is then going to tip that balance that we saw earlier of pronation and supination, and one's going to become more dominant. So I recommend these to a lot of my patients to have a look at, just from an education point of view. Anyone who wants to know a bit more about the way feet are working, these are really good. That one at the end, Gay Happens, 2 American ladies, and it's really good. Definitely worth looking at. So back to that journey. So we're here, so after all of that, we're here, done the course, the applications are working, I've tried them on myself as well, because I've got a bad back, I've got an L2 facet joint irritation from an old sporting injury, so that's always, my back's always been out. So I remember I got into kettlebells, I'll do a windmill. gone, couldn't walk, it irritated it. Saw my physio, massage it, wrench it back into position, off you go. The problem is there's no conditioning given to you to do. So all I thought, yeah, you want to do a bit of with the bands, get the whole rotation going. But what I've been doing is the exercises here, I've learned, and it's actually loosened it right up. And it works really well. So I haven't been in pain for quite a while now since doing that, but it really does loosen things up, gets you working again. So you know when you've applied it yourself, which is more doing the I move freely movements because you can't assess yourself, and they've just helped. Back's nice and free, works, and also loosening up the hips definitely help. From my point of view, in developing my private practice, so I'm in clinic during the day in hospitals, locuming on the NHS. My clinics are typically in the evenings, between 6 and 9, maybe a couple of times a week. Having looked at the whole biomechanics thing, I haven't got time to do all of that. So I'm happy to do the base layer of the pyramid. But looking forward is when I'm speaking to Rachel saying, I'd happily collaborate and say, well, I've filled up the links, man, knowing that's something we all do consistently. This is what I've got, but I'd rather say to a client, go and see someone who's going to know what exercises to do to improve this. That's not something I've ever done in my career. I'd feel pretty stupid going to, right, let's do this. Get on the floor, let's do these exercises. I'm more clinic-based in a typical hospital setting. I just feel like a fish out of water doing that. But doing that first layer of assessment is where I can apply my strengths, apply my experience, know that can work. So, good thing is I've reached out to a few independent physios, and we're working with them, and saying to Rachel, just from a biomechanics point of view, like that lady, the horse injury, not horse, yeah, so she's a Paralympian in equestrian events, and she ended up with motor neuron disease, and now she walks with 2 crutches, really come a long way from being, quite out of position. Her dream is to get back on a horse, but just casually, and we've got her in splints on both sides, so AFOs on both legs, crutches, walking forward. And so my colleague said to me, he goes, oh, you do all that biomechanics stuff, do you want to treat her? I thought, yeah, I could. Firstly, she's up in Milton Keynes, I'm in London. And secondly, I know from people who've spoken to, people on the course, they're biomechanics coaches with an interest in horse riding. So you're more suited to see someone like that. So that for me, if I'm thinking what's the forward plan, it's to work with biomechanics coaches in that way. You've got your links man, I'll send you the one I've drawn up, you can send it back, and it's all part of a whole holistic package. So yeah, that's my plan going forward in terms of how to develop the business. And any questions?